Good morning. My name is Wendy Johnson, and today I'll be presenting to you a patient safety teaching on reducing patient falls in the acute care setting. I'd like to thank you for taking the time out of your schedules to be with us this morning at this presentation. So before we get into the details of the presentation, I think it's first important to define what a patient fall is. A patient fall is an unplanned descent to the floor with or without injury to the patient. The causes of patient falls are many, and over the course of the next few slides, I will discuss in detail the causes. So the first cause is organizational. When it is determined that the causes are organizational, patient safety awareness is not prioritized or ingrained in the organizational culture. Policies and prevention measures are not adequately reinforced or communicated. There's a lack of staff supervision, ownership and accountability, and typically there's inadequate training and education to the staff. As it relates to environmental hazards, lines, tubings, cords in the pathways of the patients, beds in the highest positions, unlocked wheels, all bed rails being in the up position, and wet floors are some of the environmental hazards. As it relates to staffing issues, as we know, nurses or nursing comes with high demands on the staff, and so some of the staffing issues are high nurse-to-patient ratios, inadequate or infrequent rounding, and delayed responses to the call bell. Additional causes include ineffective communication. It cannot be understated how important it is to communicate effectively in nursing, not just with the patients, but amongst ourselves as professionals as well. Some of the examples of ineffective communication include poor report handoffs, where the fall risks are typically not communicated to the oncoming staff. Fall risk or prevention measures and protocols are not communicated to the patients and their families. As it relates to inadequate assessment, fall risk assessments are typically not completed or they are inadequately performed. Other causes include high-risk medications, many of which are opioids, antihypertensives, and hypnotic drugs. Those drugs typically cause decreased levels of alertness, hypotension, dizziness, and altered mental status. And of course, these are things that are changeable or can be decreased, but however, they still continue to be a problem, and they do contribute to falls. Patient-related issues will include altered mental status, elimination issues, impaired mobility, poor impulse control, and of course, pain. So because patient falls continue to be a problem in the healthcare setting, the Joint Commission has found it necessary to put things or campaigns in place to address this issue. And so patient falls is a patient safety goal of the Joint Commission. So what is a patient safety goal? The National Patient Safety Goals is a set of methods supported by evidence-based research that is established by the Joint Commission to promote patient safety across various healthcare settings. So much so that in 2011, the Joint Commission Center for Transforming Healthcare launched its Preventing Falls project amongst 7 hospitals throughout the U.S. So why is this important? As we mentioned, falls continue to be an issue or a problem in the healthcare setting, and so the goal is to reduce the incidence of patient falls in the healthcare setting and to improve patient outcomes. It's important because falls ranks in the top 10% of patient safety problems. 700,000 to 1 million falls occur in the U.S. hospitals annually. Falls result in death, increased lengths of stay, and hospital costs. Most falls are preventable. It affects the entire population, and it's a very complex issue, and it's very difficult to solve. There is no one-size-fits-all solution. So if we were to reduce patient falls in the healthcare setting, how would that impact patient outcomes. So reduction in the number of patient falls or injuries would yield improved patient outcomes and cost savings. According to the Health Research and Educational Trust, the Fall and Injury Prevention Program that was headed by the Joint Commission Center for Transforming Healthcare among the 7 hospitals yielded the following results. There was a 62% reduction in the falls resulting in injury. There was also a 35% reduction in the overall falls rate. As you can see, those numbers are very astounding, and it proves that if falls are reduced, they will yield better patient outcomes. Through the implementation of the Falls Prevention Program, a 400-bed facility can expect 134 fewer injuries and cost savings translating to $1.9 million annually. Again, that supports the idea that if falls are reduced, it can positively impact patient outcomes. So to support the case that we need to reduce falls in the healthcare setting, I've included a case study that was conducted at the Bassett Medical Center in Cooperstown, New York. And I'll give you a bit of a background about this institution and what they had done. So the hospital is a 180-bed inpatient teaching hospital, and they were participants of the Preventing Falls with Injury project by the Joint Commission. The project took place on an inpatient medical unit, and they had done a root cause analysis using the Six Sigma DMAIC framework, which revealed that falls on the unit were attributed to human factors, including patients' reluctance to call for assistance. And the DMAIC means define, measure, analyze, improve, and control. The subjects were adult patients on the unit, 18 years and older, that were admitted to the inpatient medical unit, and they were followed from admission to discharge. The interventions that were used were that they launched a campaign called Call, Don't Fall. It involved the full support and participation of the leadership and the unit staff, and it's found that whenever the leadership of an institution is actively involved in reducing patient falls, the successes of their campaigns are usually better. It is often said that the leadership of an organization dictates the culture of the organization, and we found that to be true in this particular case study. In addition to that, they had also done a unit-wide education to patients, the family, and the staff. They did a review of the fall safety document that assessed the fall risk and reviewed the fall prevention measures. Signs were placed in the patient's rooms with reminders to call for assistance before getting out of bed. Chair alarms were placed, and there were also color-coded fall risk identifiers. Continued interventions include 2 daily unit huddles that were geared at identifying patients who were at risk for falls. And if these patients were identified as being at risk, they were rounded on every 2 hours, with emphasis placed on providing assistance with toileting. They also did post-fall huddles to review cause and to take necessary corrective action. And finally, they did a weekly review to evaluate the trends. The results of this study, again, were very astounding. It showed that there was a 43% reduction in the number of falls, and again, this supports the idea of the patient safety goal to reduce patient falls in the healthcare setting. So, again, to support this idea, I've also included 3 evidence-based research articles to support the idea. The first is entitled "A Hospital Systems Approach at Decreasing Falls with Injuries and Cost." In this article, the sample were patients across a hospital system that comprised of 50 hospitals in 11 states. It was a system-wide, multifactorial, evidence-based fall prevention program that was implemented over a 4-month period across 50 hospitals. The fall team included various disciplines and hospital leaders, including the CNO, the Chief Nursing Officer. The goal was to reduce the incidence of falls. The program was shared through the use of webinars, conference calls, and workshops. Some of the interventions that they had implemented were interdisciplinary fall teams that created a fall prevention program that focused on individualized multifactorial interventions for each patient that were identified as at risk for falls. The interventions included hourly rounding, the use of sitters, patient and caregiver education on fall risk and prevention measures, handoff communication, physical therapy evaluation, a system-wide fall prevention campaign with workshops and educational sessions across all disciplines, and the use of fall risk bracelets, restraints, bed alarms, special flooring, and hip protectors. As we can see, the results were again very, very astounding. There was a decrease of patient falls by 58.35% over a 2-year period since the program was implemented, and cost savings yielding over $770,000. As you can see that these interventions were valid, and the results of this study showed improved outcomes. The second evidence-based research article was entitled "Bedside Nurses Leading the Way for Falls Prevention." The sample included patients in a 30-bed medical progressive unit at a 200-bed hospital in the Midwest. The unit had experienced 37 falls in 1 year, which accounted for 46% of the total falls in the hospital, and I think that's a very significant amount. This equated to 3.92% fall rate that was higher than the NDNQI's benchmark of 3.37%. So as a result, this prompted the need to implement interventions that were geared at reducing falls on the unit, and the Falls Prevention Project came about as a result. The project including ongoing in-services and workshops utilizing video presentations and discussions. In addition, the falls policy was reviewed with the staff, as well as education and documentation requirements, the falls contract, and the Morse Fall Scale. The Fall Prevention Project was entitled No Fall Zone, and again that included ongoing and improved education of the falls policy, implementation of a falls contract, the falls risk signs being placed above the patient's beds as well. The results of this article also showed that there was a significant amount of decrease in the number of patient falls by more than 50% over a 2-year period since the program was implemented. The cost savings were over $500,000. Again, this study supports the idea that patient falls in the healthcare setting is a problem, and then that the interventions need to be put in place to reduce them. The third and final literature, evidence-based research literature, is entitled Creating a Protocol to Reducing Inpatient Falls. In this sample, 40 patients were randomly selected in an 800-bed hospital in England. The hospital had experienced over 1,900 falls over a 12-month period in 2007. This prompted an investigation and ultimately a campaign to reduce the incidence of falls. The interventions that were implemented resulted in the reduction in the number of falls in a 1-year and 2-year period. The interventions included the implementation of a fall prevention protocol that included a falls risk assessment at admission, a falls risk assessment care plan for patients who were identified at risk, and a risk versus benefit assessment of bed rails. Training sessions were provided by senior nursing management, and newsletters, posters, and emails were sent to the hospital staff. The results of this study showed that there was a decrease of patient falls by 10.2% after the first year and by 17.1% after 2 years. In raw numbers, it showed that there was a reduction by 500 falls in each of the years. Again, this literature supports the idea that a reduction in patient falls yields positive outcomes. So what are the recommendations to healthcare facilities? As we've seen, it continues to be a problem. There is no one-size-fits-all solution. And so as a result, it's important for us to establish a culture of patient safety awareness, make it a top priority. We need to conduct a root cause analysis utilizing robust methodologies to measure all potential contributing variables and then analyzing the data to determine the primary contributing factors. It is also important to implement multiple interventions based on results of root cause analysis. Again, there is no one-size-fits-all solution. And finally, it's important to provide ongoing evaluation and reevaluations of the interventions and to ensure continued success. This concludes today's presentation, and again, I'd like to thank you for taking the time out of your schedule to be with us today.
Thank you. It was great.
Thank you.